We have gone into this under the assumption that this experiment will be a permanent change and a permanent fixture in our benefit package and in our program. And in order to do that, we're going to have to prove the cost effectiveness of these new services, which we believe that we will be able to do.
Welcome to The Other 80. I'm Claudia Williams. If you've listened to even one episode of this podcast, you'll know I'm a policy geek. Many of you are too. And here's what us policy geeks can't get enough of: the juicy details on how states are combining medical and social care in the Medicaid program. I see it in my podcast statistics. Some of our most listened to episodes are the ones with J.C. Cooper and Palev Babaria on CalAIM in California, and with Mandy Cohen and Cody Kinsley on healthy opportunities in North Carolina. And now, our gaze shifts to New York. The Empire State is launching one of the most ambitious programs yet. New York Medicaid Director Amir Bassiri joined me to talk about how it's going and what comes next. So please welcome Amir Bassiri to The Other 80. It's so wonderful to welcome you to this show. Thank you for joining. And you said that this is a big week for you in New York. I especially appreciate your time.
Absolutely. Thank you for having me.
This is going to be a conversation that focuses on New York Medicaid and the waiver that you've just recently been implementing. I always think of waivers as experiments or pilots where you're trying to test new ideas. So without getting into the design of the specific components, what are some of the core ideas that you're trying to test through this new amendment?
We actually amended our entire waiver to include a new goal and purpose for the evaluation regarding the integration of health-related social needs into the managed care benefit and the impact of those services on both quality of care as well as total cost of care. This new focus, which is additive, really drills down into the health equity aspect to be able to measure and improve upon some of the existing disparities for our Medicaid managed care population.
And I think that's really important what you just said, because what you're saying is that when CMS or the state looks at the bottom line in 3 years, they're going to be evaluating, did the addition of these new services and some of the other designs we'll be talking about have a result in terms of cost and quality?
Yeah, we have taken this approach for a few different reasons, one of which is really lessons learned on prior experiments or prior demonstrations where sustainability may not have been at the forefront, but became a challenge after the fact when it wasn't put at the forefront of the design and thought through systematically. We have gone into this under the assumption that this experiment will be a permanent change and a permanent fixture in our benefit package and in our program. And so we had to have that focus. It is still very ambitious for the reasons you mentioned, but we've been encouraged by the work in North Carolina, the work in California, the work we've seen on much more tailored or narrow expansions of benefits in health-related social needs. At the end of the demonstration, and in accordance with the current CMS rules, this is assumed to be embedded into our capitated premium paid to managed care plans and be a permanent benefit package that they will have to cover. So we are, driving ahead, assuming that this will be at risk at some point in time with our health plan partners. And in order to do that, we're going to have to prove the cost effectiveness of these new services, which we believe that we will be able to do.
These interviews with state policy officials are among our most popular on the show. And I think it's because so many people are trying to figure out the nuts and bolts of how to approach this. So you mentioned North Carolina, you mentioned California. You were also on a panel recently with Emma from Oregon. What were some things that you borrowed from those other states, both in terms of things that were working that you wanted to emulate, but also in terms of things that proved to be challenges?
Great question. I would say most of what we had is similar, if not the same, in terms of those nutritional services that are covered, the housing support, transitional housing support services. All of us have the same housing transitional supports. Where we deviated is we went a little further on transportation. Medicaid is required to cover non-emergent transportation for medical care, not for social care. And so we pushed very hard to get that incorporated, which we did. And then we had some nutritional services like paying for cooking supplies or brokerage fees on housing that we were able to negotiate over the 18-month process of negotiating the waiver with CMS. We asked for every single thing that we could. In seeing some of the recent submissions, there are some innovative things that we had not thought of that we could have gone forward for, things like the diapers and other aspects of recently submitted 1115s. But between, for the cohort between 22 and now, which is, I think, 10 plus states, there's a lot of overlap. And I think we were all thinking along the same lines and in accordance with the CMS guidance. Some of us went further in niche areas than others, just given the needs of our respective populations. But there was a lot of copying and pasting and talking and aligning, which was very, very helpful. I'm very appreciative to the other Medicaid directors in those other states who helped us think through what we were missing and likewise what we did with them by sharing our concept paper a few years ago.
What were some of the points of discussion or negotiation and maybe some areas that ended up changing based on that?
Great question as well, Claudia. I think there was a little bit of sticker shock from CMS when we submitted our amendment.
What was the sticker?
Originally, it was assuming a 5-year waiver, and it was $13 billion. And I think that necessitated a lengthy discussion, both in terms of how we were going to pay for the waiver, as well as what we were requesting funding for. We learned very quickly we were not going to be able to get a full 5-year demo approved. So that was a big sticking point, of course, because it required us to rethink what we thought we would be able to do in the time frame. And then, subsequently, after we submitted our amendment, CMS had released pretty extensive updated regulations and guidance on health-related social needs services, which narrowed what we were asking for with regards to adding those benefits. There was also a lot of concern from our stakeholder community because of the prior demonstration known as DISRIP and wanting to make sure there was accountability in the design and flow of funds. Things like the workforce development, things like our hospital global budget initiative, the health-related social needs services, our health equity regional organization, those all necessitated extensive, detailed discussions with CMS so that they could tie the intended use and authority to existing and precedent approvals from before. And, we got there, fortunately. It did take some time. It was worth it. I have to give credit to the CMS team, just given the backlog that they were dealing with. We had a lot of in-person meetings. They were very, very patient in working with us. And we finally got there, but I wish we had 5 years.
Yeah, right. I think the final amount is $7.5 billion, with the majority of that coming from the federal government. Is that correct?
$6 billion of the 7.5. Yes.
The first element we're going to dig into, because I think it's a really interesting new approach, is the establishment of the regional social care network. So, and I'll give the listeners a little overview, and you can correct me if I got anything wrong. So the state has contracted with 9 different regional organizations. Their job is to assemble the network of community-based organizations, CBOs, that will be delivering health-related social needs services, whether that's housing support or food or whatever that might be. And then they'll be getting a pass-through amount from the health plans as a single payment per member per month. So imagine it is like there's an automatic pass-through, goes to this regional organization. That organization looks across the landscape, figures out who to contract with, pays those entities, and just sort of is accountable for that ecosystem of CBOs. And this is different because in California, that was the job of the managed care plans to do that kind of work. And so let's just pause there for a minute. And if you could talk about what was driving that decision first, and then let's talk about how it's going, what the structure is, and you can add any details that I missed.
You have it right. They are required to be entities that can contract with a health plan, take risk, be an IPA, be an MSO. But their primary purpose, as you said, was for a designated geographic region. They are responsible for developing and connecting local community-based organizations to the social and IT platform that they're using, so that they can provide these new services. They can be reimbursed on a fee-for-service basis for these services, as well as link individuals to existing local and federal supports if they're available. And so that social care network is intended to bring them into the system without interrupting their core competency, while at the same time preparing us for what we were talking about at the top of the hour, which is sustainability and having health plans and these new networks be at risk in the premium, be contracting as partners, and managing total cost of care for everyone in the geography. So we had previously in other demos excluded the health plans from both the development and the funds flow. And we saw the aftermath of that in trying to get the health plans into or part of the design after the demonstration was very challenging and has had a lot of issues. So this time, as part of this waiver, health plans are still at the center of everything. They are still the accountable entity for these members. And we want them to be contracting for these services with the social care networks. And what the benefit is for the health plan is, yes, you have to contract with multiple social care networks, but we've standardized a lot of the infrastructure so that you're not dealing with 9 different processes, 9 different data forms, 9 different surveys. We are mandating the use of the Accountable Healthcare Communities Survey. That has to be the survey administered at the local level by the social care networks and their care community health workers or other care managers. So there's standardizing of the data. Having health plans at the center of that we felt was very important. And again, because we intend to have it baked into the health plan premiums after the demonstration's over, we wanted there to be some familiarity with submission and collection of these social care claims and an understanding in the health plans to be bought in on the delivery system reform.
Yeah. And it's interesting. You're sort of in the middle. North Carolina, I think, largely has the social care being outside the plan structure.
Yes.
California, it's completely within it. And I think you're somewhere in the middle. So it'll be interesting to watch.
Exactly.
So when you were looking to make the selection and really looking for what attributes would be best serving the regional areas, what did you really prioritize in selecting those social care networks?
It's a great question. We developed, my favorite RFP that's ever been released by the department. But in essence, we looked at a range of different things. One was existing capability and competency. We were aware of some existing entities doing this work in the downstate, especially the New York City area, as well as upstate, that actually had evolved from our initial demonstration, which is really what led to this whole regional social care network approach. Is the prior demo did have entities that sustained throughout the state, and we wanted to build off of that success and build off that infrastructure, because to CMS's point and credit, they did not want to provide a ton of infrastructure funding given prior demonstrations. So we looked at existing capabilities and partnerships, and then we looked at their CBO networks, how they were going to approach the CBOs, how they were going to integrate the CBOs with the physical and behavioral health providers, how they were going to use capacity building funding, How are you going to help CBOs actually do this work
Mhm.
or get them to do this work if they are interested in doing this work? How are you going to meet network adequacy standards? How are you going to contract with health plans? What are the partnership opportunities? Like, how are you going to link people to existing local and federal funding opportunities? Who are your housing partners? How are you getting housing inventory? How are you sharing data? All these types of questions, which really you do need to have some existing experience to be able to respond to. And we knew there was a presence throughout the state at various levels, and we were hoping partnerships formed in areas where maybe one had the capability but wasn't familiar with the financial management, the risk bearing entity requirements that are associated with contracting with an insurance company. So that actually played out very nicely in that we had a nice mix in the results of existing entities that have evolved since the prior demonstration, as well as entities that came together in a specified region that may be more rural that leverage the capabilities of each of them. One may be better suited on the organizing, the engagement, the partnership development. The other may be more better on the IT, on the financial, on the data flows. And we saw some of those partnerships come together.
I know, having written RFPs in the government, it's sort of like your baby, where you imagine this future world and you just hope that other people see the same possibility in your little baby. So it's so exciting that you are at this point. I want to pause for a minute on one thing that I think will be important when we talk about the outcomes. One of the requirements that you have, which I think is different from other states, is that every single Medicaid enrollee be screened for social needs.
Yes.
Why is that so important? And who's accountable to do that? And what does that look like?
So this is super important to me. And I'll tell you why it's important because, in essence, we're putting forward a strategic plan on addressing health equity through this demonstration. And there are so many gaps in what we know about our existing members that to me is just honestly embarrassing. We don't have standard race, ethnicity, and demographic data for all of our members in a consistent, meaningful, and reliable way to be able to identify those gaps by region, by stratified by our populations. And I'm not okay with that. I don't think anybody here is okay with that. And so we wanted to, as part of this process, while we're screening for health related social needs and we're delivering health related social needs to those members that have and meet a certain set of criteria, we still want to know everything we possibly can about our existing managed care population. And so that is part of the reason why everyone is getting screened. We have too many gaps of self reported or unreliable comparisons from different places to really know how to act on the data we have behind our members, how to engage with them in a more meaningful way, and how to bring them into the system. Because the waiver and the populations we're aiming to really comprehensively serve are the harder to serve populations that have comorbidities, are suffering from chronic homelessness, are children, or have other chronic conditions. So that is a primary reason why all are being screened.
And I can see, as you move towards what you talked about before, which is actually putting that payment at risk, putting those networks at risk, you're building the data foundation for ultimately being able to put out fair payments
Exactly.
that are based on reality versus trying to figure that out at the end of the 3 years.
Absolutely. And I'll go a step further even and say not only does it get the payments right, but it's also, potentially to account for the populations in our health plans more appropriately through social risk adjustment to account for those underlying social needs that may exist that we don't know today in our current data.
Want to dwell for a minute on data. And you may know that I ran one of the largest EJs in California. So I'm very familiar and also worked on those policies at the federal level in the Obama administration. But before we get to the specific entity, I wanted to sort of take a step back and say, at least from my understanding of what you're trying to do, you have two big data opportunities and challenges. One is to, at the end of the day, know what impact you had on a population, both in cost and quality and other things. And so for that, you need really robust and very comprehensive aggregation analytics, right? You need to be able to look at the whole group. But you also want your care teams, whether those are on the physical health side, social health side, to have an understanding of a specific patient that's in front of them. They need to understand, like, this person was screened, here are their needs, which requires a kind of networked interoperability across a big network of organizations. And those things often get smushed together, but they're actually potentially very different infrastructures or challenges. So I want to just take a minute and have you describe, what is the data infrastructure you're building? How might you be relying on, you mentioned I know the Shiny, which is your statewide, as well as your regional HIEs. Draw that picture for us of how you're attacking those two different opportunities.
Yeah, this has been the most fun.
I'm glad you think it's fun. It's so hard.
It's so hard. It is so hard. But in New York, I think, not everyone has a statewide HIE that has, 95 to 100% of providers linked into it. And so that's infrastructure we felt the need to build upon. So to your point, yes, two very different purposes behind those large data and IT system changes. What we wanted to make sure, because you asked this earlier about who is accountable for these screenings. I don't know that I answered that. We felt strongly that the accountability should be with the networks. And the reason we felt that is because the networks are employing the community and peer workers who are on the ground and who are administering and connecting with members. So as opposed to having a health system or a health plan duplicate those assessments and referrals, we thought it would be best to really require the social care network be responsible for all those screenings. Those networks have these new IT platforms that
So what would be an example?
that unite us to find help. Some may have tried to do their homegrown, but there's a couple players in that market. And those data are housed in those systems. So how do we get that into our HIE so that the health plan or another network or everybody can see, okay, when was the last time this person was screened? And what did the screening identify? Did it have any positive indicators for HRSN? Were those referrals made? Did the service get received? Not only can we, the state Medicaid agency, have visibility into that, but we wanted the system to have visibility in that so we don't duplicate these assessments and these screenings. There's likely going to be over-screening initially, and there's always people who are transient or on maybe they're Medicaid eligible now, they're not Medicaid eligible later. But we wanted to try and streamline the information flow and ensure that the information that was being housed could be acted upon by healthcare providers, SCNs, and health plans. And so that's really why we took that approach. But we tried to make sure that the screening and the flow of that information comes from the network to the Shiny, and then the referral loop would work in a similar way, but that others would have visibility into that information.
And for those who don't know, it's a sort of a similar structure of health information exchange in New York, where there are regional quote unquote HIEs, and then there's a layer above that brings the data together at the state level, which is called the Shiny. It's evolved over time, I would say.
It has evolved extensively. And it was primarily, to Claudia's point, it was a clinical exchange primarily used by hospitals.
Yeah.
But it has evolved extensively. We've had some consolidation of our qualified entities, which are those regional entities that support the Shiny, that serve as the QEs. And they've really stepped up to the plate in terms of broadening their capability, working with the CBOs. So the Shiny and the QEs have been out in the community connecting CBOs to the Shiny and having other providers connect to the Shiny, learn how that information is going to be available, is exchanged. And we changed our rules and regulations to allow for that in obviously a HIPAA compliant and de-identified manner. but it has been a long process to get there. And I think, we still have a long way to go. We did launch these services in the beginning of the year. Everyone has different capabilities of the social care networks. But what we do know is that the infrastructure that has been established, the information is flowing as it should. So we're happy about that. But the Shiny has evolved extensively, and I think will continue to evolve as this moves forward.
And to me, it's so exciting because one of the lessons I've learned in this space is you don't get to have a need and suddenly snap your fingers and have this statewide data infrastructure be in place. You are now building on the hard work of connecting every hospital feed, every ambulatory provider, getting people access, getting funding to the regions, having a shared infrastructure, using the 90/10 Medicaid funding for all of that over decade, really. And now you
Yes.
have this new idea, which is really focused on social care and focused on outcomes. You didn't have to invent it; it already existed. You're adding new data, but building on infrastructure that has been a decade in the making. So I think that's so important.
I think there's a lot of mixed feelings about that. Not everyone is as excited as we are, but they're starting to see the benefits of that initial infrastructure funding and the
Yeah.
evolution of where we're going, which has been very exciting because there's a lot of other places this can go in the future. But we are very fortunate in New York that we had this infrastructure to build from. I will acknowledge that. I don't know that every other state has that luxury.
So it sounds like the social care screening is happening at the network level using a standardized instrument. That information, along with whatever resulting referral information or claims information, is all getting shared back to the Shiny so that the Shiny now has both the clinical data as well as the screening data and the claims data from the social care services. Or not necessarily claims data, but utilization data.
Well, not the claims data, but yes, yes,
Utilization data. Okay. So that's huge. Wow. That's big.
yes. And we've set up new data lakes and new environments so
Yes.
that we can protect the data as well as evaluate what's being done in a de-identified way.
I have a long list of questions we are not going to get to, but I do want to spend a minute on the Shiro, partly because it's
Yes,
a
yes.
cool acronym, but it's also another pretty unique thing that you're putting into place, and I think evolved in your conversations with CMS as well. Tell us what that is and why it's important in this whole structure.
Yeah. The focus of this waiver was always about regionally, locally led solutions to very specific health equity disparities and needs, knowing that we have a very diverse and expansive state, and needs are different depending on where you are in the state. So we had the network concept, the social care network. It was also included to have 9 heroes, health equity regional organizations, whose primary purpose was really to make sure that the needs of the community were locally driven and led by CBOs, healthcare providers, behavioral health providers. I mean, everyone was eligible to be part of that hero, but its purpose was to document, track, identify the priorities of each region from a health equity standpoint, and then develop a statewide health equity plan. Now, as we got further along with the negotiations, it did not make sense to have 9. Well, we do need an entity looking at all of this, documenting, tracking, putting together our strategic plan to address the priorities of each region, and then monitoring our progress in addressing those specific disparities. And so that's what it ended up resulting in. So we have one statewide health equity regional organization, the Shiro, as he said. It will be responsible for 4 main functions: data aggregation. So instead of having each of the SCNs be responsible for sending us this data, then we would aggregate it all to give it out to the public. The Hero will be responsible for that. They will be responsible for developing a statewide health equity plan, doing local and stakeholder engagement at the regional level, and evaluating what is working and what is not working in terms of what those priorities were identified as versus what the networks and the plans are actually doing for the people of that region. So we'll have a little bit of accountability to be able to course correct and pivot when things are not moving on track. That's the concept. It's also, responsible for thinking of new value-based payment or alternative payment models associated with these health-related social needs services as well. But it's something we're very excited about. It is unique with the purpose of really making sure that we're taking a statewide approach, but having stakeholder input identify the health equity priorities that we aim to address.
That could be a government entity. Why is it a separate organization?
This was something CMS had sort of wanted to explicitly state. They wanted to make sure there was delineation between the State Health Information Network, the SHINY, which some could view as being that entity. They also wanted to make sure that local government, like New York City or local health departments, were not leading that entity, because the purpose of the dollars and the services are not to supplant existing activities, but rather to augment and enhance. And so they wanted there to be a clear separation of those things.
Interesting.
We have identified a lead entity that will be announced very soon. And I think, given your familiarity and understanding, I think you'll be pleased. While it's not a public government agency, it is an independent, not-for-profit entity that works with government agencies, including the state.
We will all be looking out at the news about that. Yesterday was the inauguration, and I know in Medicaid land, everyone is watching the news very carefully, anticipating that there will be some proposed changes to the program. It's hard to know what those will look like, but I think it's fair to say that they will have a cost savings bent. I've heard there's some interest in novel, innovative ways to save money, right? Which would look very much like what you're doing. But also there are more brute force ways to save money, like changing match rates and things like that. I'm not going to ask you to predict the future. I guess what I would ask is, what do you have your eye on? And what would you very much hope stays the course over the next 3 years?
Such a great question. I would say, I had my eyes on something we saw yesterday, which was a birthright citizenship executive order. In New York, as in California, we offer comprehensive coverage to a lot of individuals, including those who are quote unquote undocumented. And the focus there would have major implications based on our state law and other factors that is very, very concerning from our perspective. That one, fortunately, we believe that it's an act of Congress. There's no, administration that has the authority there. But the other things, I think your point on federal matching rates, and specifically federal matching rates for the ACA expansion population, the single childless adults, that would be fiscally, just catastrophic and shifting costs to states that I think all states would agree is not really a cost savings proposal, but a shift in cost. We are very cognizant of the attention around provider taxes, and seemingly an area where there is some bipartisan support. So that's a little concerning from our perspective. And then obviously on the 1115s and the demonstrations, we have an 1115 amendment. We also have a 1332 waiver for our marketplace population. And most of the funding in our 1115 is utilizing a policy that the prior administration had somewhat attempted to rescind. And so there's a little bit of concern with regards to how that will be treated. What authorities do they have? Can they take things away? But I would say the biggest concern is, from New York's perspective, is we will have to negotiate our demonstration, or the renewal of our demonstration, with the current administration. The waiver does expire in 27. We have to renew it beginning 1 year prior to its conclusion, which means we will be negotiating with the Trump administration on our waiver. We've done that before. It did not work out well. And so I think, that's something we're very nervous about and hoping would stay the same. But, I think That's the top thing on our mind, and something we hope the DSHB policy and some of the other 1115 approvals are honored and taken seriously as part of the renewals, because they will demonstrate cost savings, as North Carolina has showed, which we're very, very keen on replicating.
Well, listen, thank you so very much for coming on the show and for sharing and for this incredibly deep and interesting conversation. And we are all watching with great interest what goes on and excited about the program, but also about the results and the way it will really make lives better and improve health for New Yorkers. So thank you.
Thank you. It was a pleasure speaking with you and getting in the weeds. I'm happy to do it anytime.
All right. Thank you. If you go back to episode 13 of this podcast, you'll hear a conversation with Alan Weil on how states use Medicaid to create entirely new delivery systems. Alternatives to nursing homes, community health centers, the list goes on and on. Now, as states head back to the drawing board to address social needs, I'm really interested in the different ways they are approaching this new delivery system. California is asking its managed care plans to step up and build networks of CBOs, including housing orgs and food banks. And as you just heard, New York is going a different direction, creating a new set of regional entities to be the interface between CBOs and health plans. Which will work better? We don't know, but I can promise you we're going to find out. So stay tuned. This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. Check out the show notes for more information on Amir Bassiri and New York's Medicaid program. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.